We identified risk factors for allergic cross-reactivity among penicillins, cephalosporins, carbapenems, and monobactams. We distinguish between common types of superficial and necrotizing soft tissue infections, including causative pathogens. Given a patient with a superficial skin and soft tissue infection, let's recommend IDSA guideline-concordant treatment. Staphylococcus aureus and group A streptococci constitute the large majority of skin and soft tissue infections. This is a slide from the CDC, which essentially ranks different resistant organisms based on threat level. So for erythromycin resistant group A strep, this is a level concerning. So they have 3 levels: concerning, serious, and urgent, and this one is concerning. In particular, resistance to erythromycin has been increasing year after year, and erythromycin is the surrogate for the entire class of macrolide. So essentially we can consider this resistant to the macrolide antibiotics. And in addition, we're also seeing increasing rates of resistance to clindamycin. Let's take a look at the spectrum of activity of common antibiotics used for skin and soft tissue infection. Of course, here we have viral type strep pneumo, drug resistant strep pneumo, beta hemolytic strep, MSSA, MRSA, and some gram negatives. Now, in particular, we are going to focus on beta hemolytic strep and MSSA and MRSA. So you can see that penicillin has excellent activity against beta hemolytic strep, but no activity against MSSA or MRSA. The same for amoxicillin, no activity against MSSA or MRSA. And because amoxicillin standard dose has excellent activity against beta hemolytic strep, there's really no role for a high dose amoxicillin that normally will work well for strep pneumo. For beta hemolytic strep, it's unnecessary to use high dose amoxicillin. Now, when we want both beta hemolytic strep coverage and MSSA, because MSSA makes penicillinases, there is a need for clavulanate. So amoxicillin-clavulanate, excellent activity for both beta hemolytic strep as well as MSSA, but no activity against MRSA. Dicloxacillin, which is our anti-staphylococcal penicillin, has excellent activity against MSSA. In fact, one of the drugs of choice for MSSA. And in general, it has good coverage for beta hemolytic strep. But there are some strains of beta hemolytic that may be resistant to dicloxacillin. So if we have other options for beta hemolytic strep, it's best to use those. But still, it does have high activity against them. Cephalexin, your first generation cephalosporin, essentially excellent activity against beta hemolytic and MSSA, and that's true with pretty much most of first generation, second generation, and third generation. The only exception with the second generation is the cephamycins are not included. Of course, we don't have oral options for cephamycins, but the rest of second generations have excellent activity against beta hemolytic strep. Bactrim has excellent activity against beta hemolytic strep and MSSA, and also against community-acquired MRSA. Now, there is historically been a myth about trimsulfan not being active against beta hemolytic strep, and in fact, the 2014 IDSA guidelines typically do not recommend Bactrim anytime that you are covering beta hemolytic strep. However, in recent time, that myth has been debunked, and anytime that we have concern for beta hemolytic strep, trimsulfa is an excellent choice. With clindamycin, as I mentioned, there is increasing rate of resistance in beta hemolytic strep. The same in community-acquired MRSA, there is increasing rate of resistance to clindamycin. It does, however, maintain good activity against MSSA. Ciprofloxacin in general has poor gram-positive coverage. It can cover MSSA, but no coverage for MRSA or beta hemolytic strep. The levofloxacin and moxifloxacin, those are the two that have excellent activity against beta hemolytic strep, as well as MSSA. And levofloxacin doesn't cover MRSA, but moxifloxacin can cover some community-acquired MRSA. But the rate of resistance can also be might be increasing in moxifloxacin. Azithromycin and the rest of macrolides, so erythromycin was the surrogate for this class. As I mentioned, rate of resistance in beta hemolytic strep is increasing, and that's very concerning. Still active against MSSA, no activity against MRSA. And lastly, the entire class of tetracycline, so doxycycline, most commonly used as oral agent, has poor activity against beta hemolytic strep. So anytime you need beta hemolytic strep coverage, you should not be using doxycycline. It is an excellent choice if you need MRSA or MSSA coverage. So it's oral and excellent coverage against community-acquired MRSA. Here are the IDSA recommendations for the management of impetigo and ecthyma. As we have discussed previously, impetigo is essentially the infection of the epidermis. Ecthyma can also go into the dermis layer. So ecthyma is deeper level, so that's something to keep in mind when we're deciding to use topical or oral agents. So in general, we know that the most causative pathogens are MSSA, most common, and beta hemolytic strep. So with impetigo, because it's only in the because it can be in the epidermis only, we can use topical agents. So these are some ointments and creams that patients can apply to the area, and that's best because it goes to the site of infection and it doesn't cause collateral damage, for example, affecting the gut microbiome. Now, with both impetigo and ecthyma, because it goes to dermis layer, oral antibiotics are recommended. And the way you choose between topical and oral for impetigo, essentially the number of lesions affected, and also if there are multiple people in the household might be at risk of getting the infection, so for infection control or transmission control. But anyway, for oral treatment options, when targeting MSSA and beta hemolytic strep, which are the most common causes, oral agents, cephalexin, amoxicillin-clavulanate are the best coverage. So cephalexin most commonly. The problem with cephalexin is that patients have to take it 4 times a day, whereas amox clav you can do it twice a day, so it's nicer. Other options include dicloxacillin and clindamycin, so they may not be the best for beta hemolytic strep, but they are available options in case the other ones are not available. And of course, Bactrim will also cover MSSA and beta hemolytic strep. In general, Bactrim is reserved when you need MRSA coverage. Clindamycin is not the best thing for MRSA coverage. So Bactrim and doxycycline have much better MRSA coverage. Now, if you do use doxycycline, keep in mind that it does not cover beta hemolytic strep. So if you're using doxycycline for MRSA coverage, you need a second agent to cover beta hemolytic strep. And there is no need for IV treatment. So impetigo, relatively, the least severe type of skin and soft tissue infection compared to other types of skin and soft tissue infection. Now, gram stain and culture of the pus are recommended, if available, but it's, treatment without these is also reasonable. So, if you don't have culture results, you can totally do these creams or these treatments for 7 days and you'll be done with treatment. Now, these are the regimens that I had mentioned, so keep note of the frequency of doses, because some of these that are 4 times a day, they are less likely to have adherence in patients. Now, slightly more severe is purulent skin and soft tissue infections. So these are things like abscess, carbuncle, furuncles, and essentially for treatment of these, which, because pus is driving these, so these are purulent, the large majority are Staphylococcus aureus, okay, either MSSA or MRSA. And it is possible to have beta hemolytic strep, right? So Streptococcus pyogenes could be pus generating, but in general they are rare. So the treatments are essentially targeting Staphylococcus aureus. Now we do need to assess the severity of purulent infections and break it into mild, moderate, and severe, and that's driven by presence or absence of SIRS criteria. So if no systemic signs of infection, that's essentially mild, and all you need to do is incision and drainage. So essentially it's a source control strategy. So once you remove the pus, the patients will recover. So no need for antibiotics. Now, if there are systemic signs of infections, and the patient should, of course, be hemodynamically stable, in addition to incision and drainage, the patient will receive oral antibiotics. Okay, so oral antibiotics that's primarily targeted at MRSA. So trimsulfa or doxycycline, and for some reason, if these are not available, clindamycin. Clindamycin last choice, not only because of increasing rate of resistance, but also collateral damage from clindamycin is much more severe. So C. diff in particular is an issue. Now, if there are culture results available, of course, we want to de-escalate once the culture results come back. Of course, these are pretty narrow in general, so there's not much we can de-escalate. But for example, when we go to severe, and that's essentially if somebody previously had incision and drainage and PO antibiotics and they failed treatment, they essentially get labeled as severe infection and they would require IV antibiotics in addition of incision and drainage. Or if somebody had multiple systemic signs or plus acute hypotension, organ dysfunction, or if somebody is just immunocompromised. So if it doesn't have any of these, purely if a patient is just immunocompromised, we will consider that a severe infection, and they will have to receive IV antibiotics. And again, antibiotics are targeting MRSA. So our drugs of choice are vancomycin for the largest, for the most part, but also daptomycin, linezolid, ceftaroline. And there are some, long-acting anti-MRSA agents that we have that even a single dose is good enough. These are dalbavancin and oritavancin. Their half-life is somewhere between 200-300 hours, so they're pretty long. So a single dose will actually last for a week or so. So IDSA guideline recommendations do say to gram stain and culture of pus, are recommended, but again, depends on the severity. So you may not necessarily need those. Incision and drainage is the cornerstone of purulent skin and soft tissue infections, and we discussed how to choose anti-Staphylococcus aureus agents. For clindamycin, one thing that's become significant, especially when we have to de-escalate based on culture and susceptibility results, is the concept of inducible clindamycin resistance and the D-test. So in general, clindamycin resistance is very common in healthcare associated MRSA, and that's why we don't use it anytime we suspect MRSA in hospital associated infections. But it does have activity against community-acquired MRSA, but as I mentioned, the rate of resistance is increasing. Now, the concept of macrolide inducible resistance to clindamycin is very interesting. So there is the MLSB phenotype, and that essentially stands for macrolides lyncosamides, which essentially clindamycin is the only drug in this class. So we usually just say clindamycin, but lyncosamides and group B streptogramins, quinopristine, which we don't really use clinically, so you will not really see this in this course. But this phenotype essentially is a cross resistance between these three classes of drugs. And what that means is that the resistance is the results of an enzyme. So it's a methylase enzyme that's encoded by a plasmid-borne gene called ERM or ERM. And so this gene needs to be active to produce this enzyme, which will break down all three of these classes, right? So, this gene could just be always on. So we call that constitutive expression of the gene. So if it's always on, when you get your susceptibility results back, you will see that, Staphylococcus aureus is resistant to erythromycin and clindamycin, and of course cunnipersin, which we don't really test since we don't use it clinically due to a lot of adverse effects to that. Now the other thing that can happen is inducible. So maybe this gene is not always on in Staphylococcus aureus, but maybe it will be induced when you use one of these agents. Okay, and most likely if it's inducible, it can easily be induced by macrolides. It may take longer for clindamycin to induce this, and essentially all these have the same binding site, and that's why there is a cross resistance and the same mechanism. So the problem is, if it's inducible and you get your susceptibility results back, it may show resistant to macrolides, but susceptible to clindamycin. And that's a problem, because then you might say, okay, it's resistant to macrolides, so we don't use macrolides, but we will use clindamycin. And then while the patient is receiving clindamycin while on treatment, resistance might emerge and lead to treatment failure. So the way to catch inducible resistance is to do the D-test. So the D-test is essentially that when you have a plate, so here's a cartoon over here. So you have your agar plate where your Staphylococcus aureus is growing, and you drop two discs. One disc has erythromycin, the other one has clindamycin. And then once you drop the disc, antibodies will diffuse in a radius around the disc. And if it's killing Staphylococcus aureus, that means nothing will grow around the disc. So you have a zone of inhibition. So here's erythromycin and here's clindamycin, and that essentially means that it's susceptible to both agents. Now, if it grows through the disc, that means it didn't care that there was antibiotics here, it was resistant to it, so it actually grew through. It did nothing. Sometimes you may get, so I will use the example over here. So the panel C, you can see that there is a large zone of inhibition around clindamycin, but it is, it actually has grown close to the disc of erythromycin. So panel C over here shows resistant to erythromycin, but susceptible to clindamycin. Now that's how it normally should be, right? The D test is that if the same test shows you a D-shaped instead of a complete circle, essentially means that because, obviously this is resistant to erythromycin, and erythromycin is diffusing through this plate. So the idea is that as you get, the area that's close to erythromycin, because there is some erythromycin in this area over here, it has essentially induced resistance to clindamycin. So instead of having a complete circular shape, Staphylococcus aureus was actually resistant to the area over here. So essentially means the Staph aureus that was over here got, induced, and it's actually resistant to clindamycin. Whereas on the other side, you don't really have erythromycin over here, so it did not induce resistance to clindamycin, so you have a zone of inhibition. So what that means is that you have a D shape. So this is so panel D is D-test positive and panel C is D-test negative, which means that if you have D-test negative, it's okay to use clindamycin clinically. When you have D-test positive, it's recommended not to use clindamycin, because it's possible that once the patient starts receiving clindamycin, halfway through the treatment, there may be enough induction to cause resistance to clindamycin, leading to treatment failure. Now, before we move on to non-purulent skin and soft tissue infection, I want to emphasize the role of incision and drainage, or incision and debridement. So essentially, in purulent, incision and drainage or debridement is the mainstay of therapy. Whereas for non-purulent, because there is no pus, for the most part, it's really antibiotic therapy, the cornerstone of treatment. So here, slightly more severe is cellulitis, and we know that cellulitis goes deeper into the skin, so it can actually be it can have dermis layers, as well as it can go deeper, a little deeper into subcutaneous layer. So again, with non-purulent skin and soft tissue infection, the most common cause is beta-hemolytic strep, and it can also have MSSA or MRSA as a contributing factor. Just like purulent SSTI, we break non-purulent SSTI into mild, moderate, and severe using the same criteria. So mild is no systemic signs of infection, moderate is systemic and hemodynamically stable, and severe essentially means failed PO antibiotics or multiple systemic signs plus organ dysfunction, or immunocompromised, or if signs of deeper infection. So one thing with non-purulent SSTI, we're getting one step closer to the most severe skin and soft tissue infection, which is necrotizing. So if you suspect signs of necrotizing skin and soft tissue infection, that will be considered severe. So for mild, so note that incision and drainage is not driving treatment, so it's antibiotics. So for mild, we do use oral antibiotics, and this is geared towards beta-hemolytic strep. So penicillin is okay. The problem with penicillin is 4 times a day. So even though we're not covering Staphylococcus aureus, penicillin is okay. So people usually don't use it just because it's 4 times a day. Cephalexin is also 4 times a day, so it has the same problem, but it also covers MSSA. Trimsulfa, which is not in the guideline because they thought that it doesn't cover beta-hemolytic strep, but we have learned that it does. Amox clav is also not included in the guideline for some reason, but we know that it has excellent activity against beta-hemolytic and MSSA, and it's twice a day dosing, so it's very convenient. And then for moderate, you want to go to IV antibiotics, and also with mild, so it's more, these patients can be treated in the outpatient setting. With moderate, IV antibiotics. So these patients typically get hospitalized, not only because IV antibiotics, but this is getting one step closer to severe, which can lead to necrotizing skin and soft tissue infection. So this is, why although these patients are hemodynamically stable, we use IV antibiotics because we want to manage this as soon as possible to minimize the risk of necrotizing skin and soft tissue infections. So for these patients, of course, cultures of blood and cultures of swabs of of the infection site is recommended. And when targeting beta-hemolytic strep, penicillin is still recommended, except this time it's IV. Now, when covering both beta-hemolytic strep and MSSA, cefazolin is the drug of choice. So first generation, some people might use ceftriaxone is once a day, but it's more likely to cause collateral damage, ceftriaxone. And of course, clindamycin is there too. And then for severe, this is where, you want to really act quickly and, mobilize multiple teams, including surgical evaluation is really important to make sure that it's not getting to the necrotic point. And at this point, broad spectrum antibiotics are actually recommended. So I know that we're trying to cover beta-hemolytic strep and MSSA, but we're actually gonna cover gram negatives because this is getting serious. So we don't want people to die. So vancomycin to take care of MSSA, MRSA. You do want to cover MRSA for these severe infections. So vancomycin plus piperacillin tazobactam is what's routinely used, and also these have anaerobic coverage too. So piperacillin tazobactam in case there is necrotic tissue with anaerobes growing, they have pip-tazo. Now the guideline has listed carbapenems because they also cover gram negatives, including multi-drug resistant gram negatives and anaerobes. So in general, we want to avoid this if we can because of the collateral damage from carbapenems. And of course, when the results of culture and susceptibility are back, we want to de-escalate as quickly as possible. Here are the recommendations from IDSA guidelines, so in accordance with what I had on the previous slide. So please pause this video and review these recommendations. One thing I want to emphasize, duration of treatment for cellulitis is 5 days. So 5 days, unless the patient is not improving, but if everything is going according to the plan, 5 days is sufficient. And lastly, the guidelines say for systemic corticosteroids, so for example, prednisone 40 mg daily for 7 days could be considered in non-diabetic adult patients, and that is essentially to control the inflammation in the site of infection.